The city is taking a new step toward breaking the cycle of homelessness thanks to help from Citizens Bank. The bank's giving $50,000 to expand a housing program for the chronically homeless. The program concentrates on people most likely to need emergency response and treatment at hospitals. A recent local survey found the cost of care for 35 homeless people with chronic health problems was more than $3 million over less than a year.
These are folks who literally are often found lying and even you could say dying on the sidewalk. And this is about catching them where they show up most frequently, the emergency room, and breaking that cycle.
These are homeless people who are staying in the hospitals for weeks on end during any given year because their health is so fragile. Now, when somebody's in bad health, it makes absolute sense that what they need most is a stable living environment where they can be well cared for, where they can take their medicines, where they can fully recover and really move along in their path towards high quality life.
Over time, I realized I wasn't able to see much of an impact on chronic illnesses like diabetes and heart disease and cancers while people continued to live in shelters and outside. And when we were able to help people move into housing, I noticed this dramatic change in health and quality of life. And so at some point I had a light bulb go off that housing is really the intervention that I and the medical community and the homeless services world needed to be working on.
By linking healthcare, housing, and support, we are providing quality services to homeless individuals and saving money at our city's emergency department.
Once a person's stabilized in their own housing and recognizes that their housing issues are over, they begin to be able to have more time and focus on other issues, whether it's mental health or substance abuse, addiction, or any of those problems.
Housing First programs are not only beneficial to those men and women who struggle with addiction and medical problems and homelessness, but they help us all. By focusing on permanent housing, we're not just saving money, we're saving lives.
To tell us more about the program and the principle of Housing First are the President and Executive Director of the Massachusetts Housing and Shelter Alliance, Joe Finn, and from the Boston Public Health Commission, the Director of the High Utilizers of Emergency Service to Home, or HUES to Home program, David Thomas. Thank you very much for being with us.
Thank you. Oh, thank you, Chris.
I want to start with David. Talk to me about the people that you see in this HUES to Home program. What are they like?
Well, these are clients who have been homeless for many years, many of them living on the streets and in shelter for years at a time, and have been using the emergency rooms and other emergency services in the city as a because they don't have any other way to access services at this point. They don't, and these are clients who have multiple comorbidities of substance abuse, mental health concerns, medical issues, but the emergency rooms are not a place for them to be living.
Joe Finn, what else is going on here? Because it's not just a dysfunctional kind of thing. These people could have just ordinary health problems that anybody else, I guess, could have, right?
I think, yeah, you're really right on target with that. I think that really it's a matter of utilization and how is the healthcare system being utilized. And the fact that these folks do not have housing complicates their ability to access services. So where they're accessing those are at the most costly point. And because of the fact that their health conditions are exacerbated by being homeless, they continue to worsen in their health, and at the same time, the cost of the services that are being offered, whether it's the emergency room or the acute hospital care that oftentimes follows the emergency room, really has little return. So that, again, the whole focus and why I'm so excited about the HUES program is that it really has targeted those folks who most utilize the emergency room and the acute care system, and are saying, well, let's house them, and then we can change those patterns of utilization and link them back to primary care, link them back to the health centers and the like, so that they're not in this endless cycle of in and out of the emergency room and the hospital, back to the streets or back to shelter.
David, this program is not 100% effective. I mean, housing does not instantly solve every problem, but what does it do for people exactly?
The housing?
Yes, once they have that stabilized at least.
Well, it provides a place for people to have a telephone, receive mail, receive home visits from a community, an outreach worker who would assist them in getting to an appointment or to access services of any sort. So it's really a base, a home base for folks who otherwise will miss appointments, will not receive mail, will lose belongings, etc. So it's a place where it's a better alternative to the streets in terms of healthcare, as you can imagine.
What about the mindset here? Because there are people who, for whatever reason, they're at a certain place where, for instance, they might not want to go to a shelter, no matter how bad things are. What about the receptivity to being in a home? I mean, physically, we need shelter, yes, but sometimes mentally, people are not really quite in it yet.
Well, I think that's what's unique about this particular type of program. It fits what I know we've spoken in the past about so-called low-threshold housing. Is if you talk to most people on the street or in the shelter, ask them what they need, the vast majority will answer housing. But they're not in a position where they are ready to respond, oftentimes by the nature of some of their disabilities, to what we call, compliance-based housing that has strict rules or guidelines in terms of what they have to do. But if they have a unit or some type of housing that they're invited into, they'll participate. They're willing to participate. So oftentimes, they're avoiding shelter programs or they avoid other types of housing because they just aren't in a position to respond to some of the compliance issues that they have. What this relies on is the stabilizing impact of housing itself. Because once a person is stabilized within that housing, I mean, the housing itself is the stabilizing effect, then they begin to start making more positive or better choices for themselves in terms of whether it's linking up with a mental health case manager or whether it's trying to enter into some type of treatment program or whatever. Those things, we believe, there's a higher probability by getting into housing first as opposed to trying to go through various transitional programs into housing.
Derek, can you tell me how this has worked out with some of the frequent hospital users that you were targeting?
Well, we've heard from the Boston Medical Center that their utilization of emergency room services has drastically decreased since they've been housed. We're talking about 8 folks who have been housed out of an original list of 35 of the highest utilizers of Boston Medical Center's emergency department. So we don't have exact figures yet, but we're hearing that analysis is underway, and there's been a dramatic decrease in the utilization. And we see that anecdotally. We can see that people are able to get their primary care, their preventive care more effectively. They're able to access substance abuse services more effectively, and take care of just a variety of activities of daily living that all of us need to attend to, attend to our health care, but also their lives.
Joe, the idea here is housing. It's more residential than institutional, but I imagine the people in this housing, they do need some support. So they need people in a building all the time or something like that?
Well, to be honest with you, that varies from person to person in terms of what their specific needs are. In all cases, however, they need services. Oftentimes, the low-threshold housing is mischaracterized as saying that just throw them out into the housing and don't worry about the services. But what we tell our Home and Healthy for Good providers is we're not saying it's easier, we're saying it's more difficult, quite honestly. It's really a change in the model of how those services are delivered. It's grown out of years of experience of working with homeless persons on the street or in so-called safe havens that knows that it's critical in terms of building relationships, building trust, and so that particular aspect is involved. Again, in terms of low-threshold housing, we have so-called congregate models that have 24/7 coverage around the state. We do have some scattered site that have some pretty long histories of homelessness and on the street, and the people are doing fine in the settings that they're in. So again, it's really, even though the housing models differ or vary at times, the one common theme is you have to have a delivery of service system in place. We just had recently done some research with the Corporation for Supportive Housing, and they kind of broke up our data, and the one key thing which determines success in these programs is the relationship they build with their caseworker, the person who's knocking on their door every day and checking in, saying, "Are you okay? What do you need today?" That's a critical part of success, and it's the relationships that they build, the tenant builds with
And the
people who are
continuity.
assisting them. And the continuity, correct.
All right, thank you very much for being with us. Joe Fifth
Oh,
from
no, thank you.
the Mass Housing Shelter Alliance, and David Thomas from the HUES to Home program. In a moment, we'll have more on Housing First with City Councilor Mike Ross.